Hi, I'm Representative Martin Broman of Biddeford. I'm here today to spend some time discussing an important initiative that will be on the upcoming ballot on November 7th, Tuesday, November 7th. So there are 4 questions on that ballot that you'll see on November 7th. And today we're going to discuss the second one, and I'll read it to you, and then we'll get into the discussion. So question 2 is, do you want Maine to expand Medicaid to provide health care coverage for qualified adults under age 65 with incomes at or below 138% of the federal poverty level, which in 2017 means $16,643 for a single person and $22,412 for a family of 2. So this is a complex policy area. It's really interesting. There's a lot to learn. There's a lot to understand. So I think we're just really lucky to have today with us 2 real experts, one in favor, one opposed. So I'll just ask each of them to introduce themselves. Representative Vachon, Karen Vachon of Scarborough, if you would start.
Oh, thank you, Marty. Thank you for hosting this very important topic. I'm Karen Vachon, and I represent the coastal area of Scarborough, and I am in opposition to this referendum question. By trade, I am a health insurance agent, so I have worked with a lot of individuals in the marketplace and have also worked with a number of people that are low income that were struggling to find access to health care. In the legislature, I have served with Representative Gatine on the Health and Human Services Committee, and I currently serve on the Labor, Commerce, Research, and Economic Development Committee, as well as the Opioid Task Force.
Excellent. Thank you, Karen. Drew, introduce yourself.
Thank you, Marty. I'm State Representative Drew Gatine. It's a pleasure to be here. Thank you, Marty, for hosting us. It's good to be here with my friend, Representative Vachon from Scarborough. I am a state representative. I represent part of the city of Westbrook. I've in my 3rd term in the legislature. I currently serve as the House Chair of the Appropriations and Financial Affairs Committee. Prior to that, I served 2 terms on the Health and Human Services Committee. One of those terms was with Representative Vachon. I have worked in healthcare on the administrative side since 1992, when I had the honor of serving in the Maine Attorney General's office. I've worked in healthcare since that time. So I guess it's, I don't know, coming up on 26, 27 years. It seems like a long time. I've been a longtime supporter of expanding access to healthcare through Medicaid expansion in the legislature. I'm excited that voters are going to have an opportunity to vote on this on November 7th, and very pleased to be here to be able to talk about this today. You're right, it is a complex issue.
Yeah, thanks, Drew. Yeah, thank you for the date, too. I almost got that wrong, and I will say this election will be decided by those who vote, so we just can't say that enough. But yes, this is a really complex policy area. There's a lot to learn. There's a lot to know. I mean, Drew, with all your experience and everything you've learned in 26 years of working on this issue, why do you think that people should vote yes on question 2?
Right. Well, there's a number of reasons, and you know, some of them are economic, and some are out of concern, of course, to people's health and their personal economic well-being. So Maine has the opportunity, as does every other state, to expand Medicaid, which means you're allowing people who are not currently on Medicaid to go onto the Medicaid program. Medicaid, of course, is a health care program that's funded jointly by the federal government and by state dollars. Under the Affordable Care Act, states are given the opportunity to serve additional populations on their Medicaid program. Unlike traditional Medicaid, in which the state of Maine receives a little bit less than $2 for every a little bit less than $2 federal dollars for every single state dollar that we put in. For most of the people who would be impacted by this, Maine will get a higher reimbursement match. In the early days of the ACA, Maine would have gotten 100% match for the newly eligible people, and then the regular match for a smaller population of people. Over time, under the ACA, that matching rate ramps down to 90%. Mm-hmm. So unlike our regular Medicaid program where you get, again, a little bit less than 2-to-1 match, under this program, for a large part of this population, we will start out by getting about 15-to-1 match, and that'll ramp down to to 9-to-1. So the economics from a state budget side are extremely good. So this gives us the opportunity to bring in federal dollars in order to support providing health care for people who right now have a hard time purchasing insurance, many of whom are not eligible to buy insurance under the exchange, so they don't get all the benefits that other folks have. So the economic benefits for those folks and for the state are, first of all, again, there are state budgetary benefits. We get a higher match for some of these folks. There are certain services, like services we provide to people with substance use disorder, services that we provide for people with mental health issues, services that we provide within our corrections system that currently we're spending 100% federal dollars for, that now we will be able to spend highly leveraged federal dollars. So we'll be getting federal dollars instead of spending 100% state dollars.
Currently, we're spending 100% state dollars, and we would be, yeah.
Yep, on some mental health services.
Yep.
So there are some benefits to the state budget. Within the broader economy of Maine, you know, these dollars come into the state and basically go to providers who are providing services. So if you are a therapist, if you are a physician, if you are a hospital, these dollars go to help, they go into the pockets of providers who are actually able to provide services to more people. So if you're a rural hospital, for example, we all know that our rural hospitals continue to struggle in this economy. These are dollars that will be able to support rural hospitals and the people that they employ. Throughout the entire state, hospitals are required by law to provide free care and charity care. This will be the opportunity to supplant some of those free care and charity care dollars that hospitals provide with actual payments for the services. So again, there are certain benefits. And then of course, because so many more people will be covered, it's projected that this initiative will add upwards of 3,000 jobs, healthcare jobs, throughout our economy. And these jobs will be spread out across Maine. Every county will have benefit, both rural areas and more urbanized population centers. So again, you know, there are economic benefits to people who will be able to become employed. And then finally, for the people, you know, last but not least, of course, you know, from my point of view, I think we all talk a lot, and I think we all believe that we want to support people's ability to work. And you know, the people who will actually receive access to health care here, to me, are people who, a lot of them really need health care, really need access to medicine, to therapy, so that they can stay in the workforce. You know, think about a person with diabetes, think about a person with Crohn's disease, think about a person with you know, some sort of a chronic heart condition. Think about a carpenter who might break their leg, or a home health aide who might hurt her back. Having access to health care gives folks the support to stay in the workforce. The majority of people who will benefit, who will gain coverage under this, are already in the workforce, but a lot of them don't have insurance, don't have access to affordable insurance, and this is what they will provide.
So you've made a case. Essentially your premise is we'll be bringing in new federal money. We'll be helping more people access health care. That'll create jobs throughout the healthcare system. That will aid our rural hospitals and a couple of other well-made points. I mean, Karen, how would you counter that and sort of push back and say, I disagree, this is not a good idea, vote no on question 2?
Okay, so we're looking at federal dollars. We're looking at federal dollars that include a match. So first of all, Maine is going to have to come up and foot part of the bill. So I liken this to, there are 2 bubbles right now that I see in our economy. We have a healthcare bubble and we have an education bubble. And it just so happens that right now my youngest son is applying for college. And what we're always looking for out of this is, we're going to pay so much money, but what are we going to get at the end, and are we going to end up with a job? So as you're looking at choosing a college, for example, when you're given an opportunity to get a huge, huge scholarship, but you still have to pay a substantial chunk of that money yourself, the question becomes, are you going to get a job afterwards? And I liken this debate to where we're at right now. I'd like to know, they're estimating that it's going to cost the state about $50 million, possibly $90 million a year on that. So the state still has to come up with that money. Representative Gatine has served on the Appropriation Committee, and we're already looking at a supplemental budget of a number of items already that are only funded in the first year that we're still going to have to come up in a supplemental budget. So this is going to cost taxpayers a substantial amount of money, number one. And I don't see a federal program as a good economic stimulus using taxpayer money to stimulate your economy. So I'm challenged with that, but I also feel as though we're going to be duplicating some services and access to programs for really specifically able-bodied, non-disabled, with no dependents. And by definition of Medicaid, those people do not even fit the definition of Medicaid. So often in this debate, what I hear a lot is it came out, we took the wording, we changed the wording and ensured that it was not insurance. But I think a lot of people confuse health insurance with access to health care. And so this whole idea is that more Mainers need to have insurance. Well, Maine right now has only 6% of our population don't have insurance, health insurance. The national average is 9%. So we don't have a lack of health insurance issue. And I would argue that we really do not have a lack of access to health care. And that comes into play with what I've witnessed directly as a health insurance agent.
So are you making a distinction between insurance and coverage?
Coverage and access to health care.
Coverage and access to health
Because,
care.
this issue is so sensitive around people's health care. Every single one of us needs health care. And the big question comes up, what terrifies all of us is, God forbid, we had something very, very debilitating, serious cognitive issues, really could not care for ourselves, needed somebody else to come in. That's what we need Medicaid for. And I feel as though this expansion of Medicaid is going to give more resources to able-bodied, non-dependent, non-disabled, and cutting back on or taking away resources from people like our Section 21 wait list, people that have real serious needs. So where I got to this place, before I even ran in the legislature selling health insurance, I would have people come into my office pre-ACA, and they would say they wanted health insurance. That's what everybody thinks they want. They want health insurance. And we would sit and take a look at it, and they couldn't afford health insurance. That's why we had the Affordable Care Act. And prior to the ACA, I would take these people and drive them over to Maine Med and Mercy and have them apply for charity care. Because Maine hospitals, by virtue of their nonprofit status, have to provide charity care up to 150% of federal poverty level. What I've seen in this debate is people say, oh, Karen, you're telling them and driving people to the emergency room. No, I'm not. What people don't realize is that you can walk in with just documentation of, in Maine Med, your last 4 weeks of paychecks, Mercy, your last 12 weeks of paychecks. And if your income is under 150% of federal poverty level, you can proactively sign up for charity care where you have access to doctors in charity care. So it's not that these people are going into the emergency room when something happens. So I feel as though we have people that could not afford health insurance covered by access of charity care. When the ACA opened up in 2014, the hospitals, the financial assistance people knew me because I had sent people to them. They started sending those people back to me because now they had access to very, very affordable health insurance through the exchange. From 100 to 138% of federal poverty level, people came to me and got insurance the first year for $1.57 a month. And they had a $200 deductible with a $400 maximum out of pocket.
Just to kind of outline this, so it's your assertion that 150% of federal poverty level for an individual is roughly pay of $18,000.
I think it was $19,025 at the time, and now it's probably come down a little bit, but yeah.
So if you make that much or less, essentially what you're saying, Karen, is you don't need this expansion of Medicaid. Another confusing thing, by the way, Maine Care Medicaid, right?
Yeah, Maine Care Medicaid are the same thing.
Maine Care is the branding that the state of Maine puts on its Medicaid program.
Yeah,
right.
so the two, it can be confusing. I mean, it's a great program, but essentially you're saying we don't need this for able-bodied working adults at this point. They have other options.
Right, because I think what you're seeing here is, I mean, with healthcare throughout the system, unfortunately, it's really complicated. You're always putting together a jigsaw puzzle, and there's a lot of different pieces. So let's work with the 150% of federal poverty level. Along comes the ACA. The people come back to me in the exchange. The hospital sends them back to me. I sit down with them. This year, at 100% of federal poverty level, they only need to make $12,060 per year to be at 100% of federal poverty level. That's working 26 hours a week at $9 an hour. So, because Maine expanded its Medicaid. So now these people have private health insurance. And I will tell you, for these people, back when they got private health insurance for the first time, it was so affordable and they loved it. And I will tell you, my people between 100 and 138% of federal poverty level, the Affordable Care Act came with a promise that was, if you like your health insurance, you can keep it. And if you like your doctor, you can keep it. So there's a fair number of people at 100 to 138 that really, really like their health insurance. Now, I mentioned the Silver Plan, and some people have said, well, what if they can't afford $15 a month premium? They can also qualify for a zero premium plan with a $5,500 deductible. And people may say, well, oh my gosh, how do they afford the $5,500 deductible? I see you're puzzled.
Well, no. I mean, let's open this up and have a good back and forth.
Okay.
I mean, all of those things are correct. You're an expert. But how does that tie to the potential of bringing in the expanded Medicaid with more federal options?
I mean, let's talk about the fact. I mean, first of all, I think what Karen, for people under 100% of the poverty, so people who are the poorest of the poor that would be covered
working
here,
part-time,
those
minimum
people are
wage.
not allowed to buy coverage on the exchange. Again, relying upon hospitals or other safety net providers to provide free care to people. Understand that most hospitals in the state of Maine are underwater and not profitable, and are the economic engines in many of our rural areas. I mean, go to places like Dover Foxcroft or Down East and go to the middle of town, and a lot of times the most viable business in that community is the hospital. And to be telling hospitals and people that work there that they need to continue to take on more and more free care obligations when there's an opportunity here to have coverage and be able to actually pay for have someone pay for those claims doesn't really seem to be a reasonable and viable option. The idea that Karen's correct. I mean, we have to put in a match, just like we do for for transportation dollars. You know, we take in lots of federal transportation money that we put match for. We consider that to be an important economic driver in our state as we try to fix roads and fix bridges. We put in matching money for federal education dollars that come into our state. We think that's important. The idea that we need to continue to put federal matching money towards healthcare, especially at a high match rate, which will be 94%, you know, if this passes in the first year, and then ramp down to 90%, I think is a very reasonable investment.
I mean, is a way to think about this, if we're looking ahead, it's 2017, and we're looking back 5 years from now. What was the right call? I mean, how would you look at that, Karen? Yes, we've expended some taxpayer money from the state of Maine, but we've had a result, and I guess your argument would be it's a negative result. It's not what we would have been looking for.
I'm looking at it. We are spending money on a program that I see to be a duplication of services, and to me, I don't see federal dollars that we have paid taxes on as being an economic driver for our economy. I mean, we've paid for that, and Maine taxpayers are going to pay for this. And when you look at the people from 100 to 138% of federal poverty level, you're actually going to be taking that insurance away from them. When you take that away,
their current private insurance,
you're taking their private insurance away, and what you've done when you've done that is private insurance pays providers at a much higher rate than Medicaid. The reimbursement rate is way lower. So when I end up working up in the more northern part of Maine, I believe that Medicaid expansion is going to decimate our provider network because the reimbursement rates are way lower. And you know, when you get into people with addiction that come in to me, when the parents bring their kids in and say, you know, what do I do? My first question to them is, do you have private health insurance? And if the answer is no, I know that the treatment options within the Medicaid network is going to be far smaller than within the private insurance network. Private insurance is always better than Medicaid, and when you're taking a percentage of the population off of private insurance, you're hurting the provider network and you're reducing the reimbursements to the doctors.
Let me just say, if you go up to northern Maine and you talk to hospital CEOs, and I think if you talk to most of the providers that practice in those areas, and there are probably a couple exceptions, but most of those providers would tell you that they're very supportive of this initiative. I mean, again, I think that Medicaid rates are low. But it is a steady payer, and it's certainly a better payer than charity care. You know, I would actually disagree. I think in some areas like mental health treatment and substance abuse treatment, I would think that you know, I think the span of services that is offered by the Maine Care program is in some respects better than what's offered by private insurance. But you know, again, I think that's something that we could disagree out. And again, I mean, we all understand the way taxes work. I mean, we all pay taxes. We pay our state taxes. We pay our sales taxes. We pay our federal taxes. To say that federal dollars coming back into Maine is not an economic driver, well, we build ships at Bath Iron Works, you know, with federal dollars. And I don't think anybody would say, you know, that that's not an important economic driver in the state. We certainly bring Medicare dollars into our hospitals, and you know, I think those are important, obviously, in order to keep hospitals and providers moving forward. So I think we understand and we can make smart decisions, you know, about how we ought to be spending tax money, whether it's federal money or whether it's state money. Right now, I'm paying federal taxes. It's going down to Washington, D.C. I'd like to see more of that money come back to Maine and support healthcare in Maine, as opposed to going to, you know, Indiana or New Jersey, or, you know, a lot of these states that also have Republican governors that have chosen to expand Medicaid and accept these
31 states plus a District of Columbia, right? That's the stat.
I think it's 31, including the District of Columbia. You know, I think we will be the 32nd jurisdiction with a Medicaid program.
Yep. So there's some argument for that, and then in this is a consideration. I know you look at, I know you understand how that works, and that's almost more of a, it's not a policy position so much as this is the way that I feel about how tax dollars should be treated.
Well, I mean, when you're working with tax dollars and you're looking to provide services to people that need assistance, you have to prioritize. I mean, we are the oldest state in the country. We are aging. There are a number of elderly services that we are underfunding. They have to take priority, and I do want to go back on Representative Gatine saying that the network of Medicaid providers is better than private insurance companies.
In some areas, I think in health, I think in mental health services and in substance use services.
That is impossible. That makes no sense because your providers are always looking for a payer mix. And yes, you have a certain amount of Medicaid dollars coming into the system, but they are really, really relying on that balancing out with higher private insurance companies paying more, and then Medicare coming in there. So say
for a given health care procedure, I don't know what a good example is, maybe a knee replacement or something, a private insurance would cover a figure and the Medicaid number would be less.
Of course.
Yeah,
of course.
yeah,
It's a negotiated rate
always.
with the Medicaid.
So along those lines, consider your network of doctors. If you're going to have your doctors signing up, and they've just come out of medical school with debt, you tell me what they want in their payer mix. They want a higher reimbursement rate.
And what they really don't want are uninsured people. They'd be forced to continue to pay for uninsured people when there could be some payment for that.
So we probably should talk about all of Maine's hospitals. They're all nonprofit, and 7 of the 10 most profitable hospitals in the entire country are nonprofit. They are not paying property taxes. They are not paying federal and state income taxes. They are not paying sales taxes. And if you look at our CEOs, our hospital CEOs, they're making, with bonuses, over $400,000 a year by virtue of their nonprofit status. They have to provide charity care. Our hospitals are not going under. Our rural hospitals are struggling, but also in the states that expanded Medicaid, their rural hospitals are struggling too. So expansion of Medicaid is not the solution to all of this. It's going to cost us a lot of money, and it's diverting resources away from people that we already have covered in the system with the 100 to 138. What's left out is the people under 100% of federal poverty level, and probably the best kept secret in the state, something that I didn't even know about until I came into the legislature, was the 144 FQHCs that are here specifically for
It's
the
federally
uninsured.
qualified
Yeah.
health centers.
Yep.
So what's an example of one of those that people might visit?
There's one at 180 Park Ave in Portland, right next to the Holy Donut.
Karen's
my favorite
place.
place. Drew knows that if we're going to duke it out, we're going to settle it with a Holy Donut.
Portland Community Health Center.
Dirty dozen donuts here in Biddeford.
Yeah.
Yeah.
Anyway, but I mean, I'm interested in that. Let's spend a few minutes on that, and then we should talk a little bit. This will play into a federal situation, which we don't really understand, and that's kind of in flux, but I think there are good points to be made there too. But we talked about uninsured patients and the ability to go to the emergency room. If I go out back here in Clifford Park and fall off my mountain bike and I don't have health insurance, if I go down here to Southern Maine Health Care, with a broken arm, they're going to take care of me.
Yes.
They may not, and they'll end up being, I'll just pay for that out of my pocket, and if it's beyond what I'm able to cover, there'll be a mechanism. And how does that work?
So with that bill, no matter where you are on that income spectrum, with my clients, if they call me, because these days everybody in the individual market has really high deductibles compared to employer insurance.
So it's
The
$5,000
majority
or
of people,
$10,000.
$2,500 in a
Okay.
silver plan,
Yep.
or $5,500. I always tell people, when you go to the hospital does a great job paying the doctors, the hospitals, and the surgeons, but then you've got a portion that you've got to pay. When they've got that bill and they can't meet their deductible, I tell them to go into the financial assistance office and work with them. They're going to look at where their income is, and if they're below 150% of federal poverty level, they're probably going to give them charity care. But then throughout the system, people are setting up payment based on their ability to pay that off.
And it's basically your assertion that those people are better off as in that situation than they would be if they had Medicaid coverage.
Yeah, because when you look at Medicaid, you've got limitations to Medicaid. For one thing, it's your state program. So if you're traveling, or if you want to go to care out of state, you can't do that. If you've got children in Medicaid that are going in college, that healthcare system isn't going to work for them out of state. So, with Medicaid, you have reduced options in the network. There are fewer doctors that are going to accept Medicaid, but there's also limitations to where you can use that.
Go ahead, Drew. How would you?
Well, again, I just think that Medicaid, one of the big benefits of this expansion is that it stops. Obviously, a situation where you fall off your mountain bike and break your arm, you're probably going to go to the emergency room, whether you're uninsured, you have Medicaid, or whether you have private insurance. But if you've got high cholesterol and are trying to manage your physical health,
Yep.
so that you don't have a heart attack someday, in a clogged artery, and end up
family history of heart disease. I need to go and get a checkup.
Yep. And if you need your regular checkup and your statin and all the other care that you're going to need to stay healthy, I think you are better off having a regular coverage, whether it's through Medicaid or some other payer. People who are uninsured use emergency rooms like healthcare clinics, and they put off care, and they put off visits, and they put off doctor visits. And I think one of the real benefits of covering this population is making sure that people are able to get that care on a regular basis. Again, we talk about this term able-bodied has been being thrown around the legislature now for the last 5 years, and really what we're talking about is people who have not gone through a formal disability process. So, an able-bodied person, as that term is used by opponents of expansion, could include someone with heart disease. It could include someone with a mental illness that has a real impact on their ability to function and their ability to work. It could include someone with substance use disorder. It could include someone with Crohn's disease or some other chronic disease. And the benefit of this is that it allows people to get more consistent health care in a way that's going to allow them to keep healthy and allow them to continue to work.
So the argument, it's a little bit like your car. You take your car in for an oil change, and that's like preventative care. If you don't do that, sooner or later you're going to have a massive engine failure and go to the emergency room. And that's ultimately more expensive than having done those oil changes.
Or ultimately, it might be the death of your car. Or the death of your body, depending on
preventive care is a better measure, and preventive care is not done in hospitals.
And we've done some wonderful things in our Medicaid program. We've implemented health homes, behavioral health homes, medical health homes, places where people go and they get, a much more comprehensive care. There's actually been real improvements in this administration and the previous administration in how we manage our program more effectively. And as those things are successfully implemented, the financial risks of putting more people on Medicare go down.
patient-centered medical home is a little bit more of a one-stop shopping type of situation, right? I mean, I think that it's built a little bit more around you and the care you need. But let's dig into this a little bit more if you don't mind, Karen.
Okay, I would like to take the analogy that you just took of the oil change for the car, and if you haven't done that, then something worse will happen, and identify this is where I think healthcare went so wrong so many years ago with the dawning of the HMO, and I'd like to roll back on that, is when we talk about health insurance, the original purpose and definition and reason for health insurance was to protect against the unexpected, the really, really costly, not planned for event. Like your homeowner's insurance and like your automobile policy. And people bought health insurance to protect their assets because they had something to lose. So you're buying into a pool where everybody's putting in that money because you know you alone could not just pay for that accident that you just had. That was the original purpose of health insurance. What happened when you rolled out the HMO, and businesses got in on providing that. Why? Because they wanted to provide a benefit for you if you got sick, to get you better, to get you back to work, because we realized that your livelihood was all centered around working. So then comes the HMO. And what happened with the HMO was the first couple of years, it was great. It paid for everything. It paid for everything preventive, and all of a sudden doctors and hospitals are going, oh, we can run this test because insurance will pay. And then more tests are being run. It just ratcheted up the cost of healthcare to the point where employers said, whoa, we can't pay for this anymore. So then along comes the ACA. And the first years when it rolled out, it was very, very affordable. But now what's happened is that insurance premiums have gone up in the individual market. They've also gone up in the employer market. So in Maine, in our individual market, if we are going to peel off those people from 100 to 138% of the federal poverty level, we're removing a portion of the risk pool. But now what we've done is we've also driven up the cost of private health insurance with a smaller pool, because you shop based on volume and discount. Right now, today, just ran the 2018 prices for somebody making 401% of federal poverty level, not qualifying for a premium tax credit. Their lowest cost premium is $671 a month. That is 16% of their total adjusted gross income in a year.
So that's pretty expensive. This is somebody who makes about $60,000 a year.
$49,000 a year. Yeah. And that's a $5,500 deductible plan with a $7,350 maximum out of pocket. So if they have that bike accident and hit their maximum, they're parting with 31% of their total adjusted gross income just in healthcare. So this is how awry our whole healthcare system has become. And it's reached a point where hospitals can charge whatever they want, insurance is going to pay. And we are not getting better health outcomes for this.
I think that's a point where there's a lot of agreement. We're just trying to figure out what the solution is, right?
We need to continue to pivot as much as we can to the question of not just access, but about cost. But I would also tell you that states that have expanded Medicaid are seeing their insurance premiums across the board going up at a slower rate than the states that have
still up, but not up as fast.
Sure. Well, let's go back a little bit on that report, because I had to look in on that. And those states, of the 31 states, they said on average 40% of their risk pool was in the 100 to 138. That is not the case. That is not the case in Maine. Only 8% of the risk pool is in the 100 to 138. And then they also looked at side by side to neighboring states. I've already gone in and looked at the pricing side by side to New Hampshire, and it's a 3% spread. But what you're seeing in the New Hampshire states is their plans actually have a higher deductible on that. So
New Hampshire expanded?
Yes.
Yeah, New Hampshire expanded, but there's a lot of variables to look into that. I mean, in terms of Maine has the highest amount of people receiving premium tax credits. So my concern is if you take and peel off the 100 to 138 out of there, and you've already seen that the private health insurance rates have spiked in the over 400% of federal poverty level, my clients are calling me and saying, I am healthy, I cannot afford this, I'm not going to carry my insurance. So there's about 9% over 401% of federal poverty level. If you lose the healthy people in the risk pool, what's left in the middle is the people in Maine that are between 138 and 400 that are heavily reliant on these premium tax credits. And now you're going to spread this out over a smaller pool. You shop for prices. You're not going to get the volume discount. I believe this is going to spike the individual health insurance market and really cause a lot of problems for the individual health insurance.
The point I'm going to keep back is, I mean, you know, we can't leave the people under 100% behind. I mean, I think that's the problem. I mean, there is not a way to keep
the people who make less than 16,000.
Yeah, there isn't a way to keep the 100, 138 in one category and still help the people under 100% because the federal law doesn't let us do that. And if we didn't have such gridlock down in Washington and same kind of gridlock we've had up in Augusta around this issue, then you know, maybe we could do something about that. But the opportunity in front of us right now is to take the people from 0% to 138% of poverty and put them onto our Maine Care program and provide them the health care that they need.
Okay, so I do want to go back on one topic that, and I thought of it and I said, oh gosh, I got to speak on that.
This will be kind of a closing statement,
Right.
and then I'll let you make one too, Drew.
Because Drew had mentioned the under 100% of federal poverty level that have not yet received their diagnosis, and for mental health. If they had access to health care, which they do, and we could get them in, once they get a diagnosis, we already have a system in place through disability to provide them care. So our biggest challenge is the uninsured. We don't know who they are. We haven't had a method to measure them. You know, a lot of them are very transient, and in a homeless population, it's very hard to follow them. You know, getting some data on them, I agree with you. Once they get a diagnosis, we already have a Medicaid system in place for them. We just need to get the true, authentic, real, able-bodied are the people that are able to work. We need to get them in a job where they can earn.
But a lot of these people, but Karen, it isn't, I mean, I don't think it's as simple as you just put it out there, because again, I think when you're talking about able-bodied, you're talking about people who have not gotten gone through the process, the long process and the difficult process of actually being declared disabled. What I'm saying is that there's always going to be people who have a diagnosis, diabetes, mental health, it could be any number of things, who need expensive, or who need medical treatment, whether it's expensive or not expensive. It's always going to be expensive to a person of low income in order to protect themselves financially and to maintain their health so that they can work. And I think those are the people who are targeted. So able-bodied to me is just a term that doesn't really mean anything unless you really try to understand that some of these people that are sort of dismissed as able-bodied are people who have real issues, healthcare issues, health issues, diagnoses that need to be dealt with, and that's why I think that this whole initiative is so important.
Well, I want to thank you both. So I'll read the question again. It's a complex area, and I'll read the question again, and then I'll ask each of you to just sort of make a brief closing argument. So, question 2 on the Citizens Initiative on the ballot that you'll receive on Tuesday, November 7th, it is complex, so I think it's good that we've gone through. The wording of it is a little dense. Do you want Maine to expand Medicaid to provide health care coverage for qualified adults under age 65 with incomes at or below 138% of the federal poverty level? And it goes on to explain what that federal poverty level means. So, Representative Vachon, you would say no, not a good idea. In sort of in an elevator pitch, why vote no?
I would say vote no because I believe that Medicaid expansion would really, really dismantle our private insurance market, would compromise our doctors' networks through lower reimbursements, and cost Maine a lot of money. And what we have not discussed today still, we have our appropriator right here, how we're going to pay for it.
Okay, thank you. Good summation. Drew, elevator pitch, vote yes on 2.
Well, how did we get here? We got here because we ran actually 7 bills in the legislature over the last 5 years. And for each one of those bills, they had strong support across the legislature. But the people who were opposed to this in Augusta absolutely refused to come to the table and refused to negotiate and try to find a solution that works for Maine. So the reason this is on the ballot is because enough Maine people now who support this have decided that they're not going to wait for Augusta, they're not going to wait for Washington, D.C., they're going to take this matter into their own hands and bring it to the people. So I'm hopeful that people are going to go to the ballot box on November 7th and support this initiative. I think it's going to have broad support across the state. We are in a situation now in the state of Maine where we had even after we went through this very difficult budget situation, we had an $111 million surplus on June 30th. So at the end of the day, after we spent money on everything we needed to spend in the last fiscal year, we had $111 million that we had collected from Maine people. We have strong revenue projections going forward in the next few years. We have had we are seeing strong growth in our economy finally, coming out of the recession, and the financial forecast for the state of Maine looks good. We have a cyclical economy just like every other state does, but I think that this would be money well spent, especially when you consider the dollars it would bring back into the state and the way that would support new jobs and our healthcare economy, especially our rural healthcare economy.
Well, it's well said. You both made compelling arguments, and I have immense respect for you both. I want you both to know that. I mean, I think we're so fortunate as a state to have such policy experts working hard on this, and I think genuinely trying to get to the same place, and just differing viewpoints on how to get there. So thanks to you both. One thing is for sure, this election will be decided by those who go out and vote. So request your absentee ballot, or I'll see you at the polls on Tuesday, November 7th. Thank you.
Thank you. Thank you, Marty. Thank you, Karen.
Thanks.